Good afternoon, and welcome to the first installment of SHM's 2020 Practice Management Webinar Series. As we are in the middle of a global pandemic, this series brings together leaders and experts from all over the country to cover important operational topics around COVID-19 on a monthly basis. Following the presentation, there will be a time for questions that will be moderated by Joshua Lapps, Director of Policy and Practice Management at SHM. Feel free to submit any questions via the questions box on your control panel. You can also use the questions feature to communicate with us if you are experiencing any technical difficulties, as your microphones have been muted. This live content and subsequent recording are temporarily open to the public during the pandemic. Resources such as these are only made possible by member dollars. If you find today's webinar valuable, we ask you to please consider joining SHM to ensure continual access to the content you need most. CME credit is available only to SHM members through our online learning portal and accessible to members after registering for a free account. Without further ado, today we welcome Dr. Aziz Ansari, Associate Chief Medical Officer and Professor of Medicine at Loyola University Medical Center, and Dr. Thomas McElrath, founding chairman of the Department of Hospital Medicine at Mercy Medical Group and the vice chairman of medicine at Mercy General Hospital, who will be comparing the COVID-19 experience in both academic and community hospital settings. Please welcome Dr. Ansari and Dr. McElrath.
Thank you. Thank you, everybody. Just a disclaimer that new with COVID and webinars for Thomas and I, this is one of our first, not what we're used to doing. So bear with us, and we hope that this is an enriching experience for everybody.
Yeah, we're used to having eye contact with folks, so it's a little different, and especially since my camera doesn't seem to be hooking up, it's even worse. So, but we're gonna share some experiences with you about our respective experiences with COVID-19.
Yep. Thomas?
So we don't have no financial relationships to disclose. We are going to be discussing some therapeutics, but we're going to be steering clear of the off-label uses because a lot of this is still investigational.
Okay. Thomas?
So the war against COVID is constantly changing, and this is clearly a moving target, but we wanted to share some early experiences in the COVID-19 pandemic.
And what we're saying is not the rules. The rules change, there are no rules. And we're really giving our mere experiences at one urban academic medical center in the Midwest. And Thomas, you can talk about your vision or your vantage point, excuse me.
Yeah, so Dr. Ansari and I have collaborated on many things, and he works at the academic center. We work at 4 community centers in the Sacramento area, 2 tertiary and 2 smaller community centers, and comparing and contrasting those experiences. Well, we're going to try and leave a lot of time at the end of this for discussion because we know that everybody else has had a lot of experience out there as well.
Yeah. And we'll also be mindful of time. It's already 3:08, and I know we have to be done by 4 o'clock. So if there's details that we're missing, as you'll see, this is more dialogue. There's not much on the slides besides bullet and sub-bullet points. Please do ask us about the details if you wish. So our overview of domains here, let me go back here, is we're going to talk about development of COVID space, COVID testing, care team and rounds, how telehealth went, go a little bit into therapeutics, but more the logistics of therapeutics. Talk about the pandemic wave. What does it mean to be over or underprepared? How do you guess? How do you guess how the pandemic is going to react at your local level? Family meetings, how has this changed communication with families? And lastly, I would really think that bring it all together. How has COVID affected your HMG and hospital relationships? So I will go ahead and start talking about floor and ICU space. So nobody was prepared for this, and we essentially we took one of our surgical units, which were individual beds. We still have dual bedded rooms in our hospital, and so we converted one unit to completely COVID. That was about 30 some beds. Very quickly, we needed one of our newer units, which was another surgical unit, which we converted to a COVID unit. So that gave us about 52 beds, which included some transitional ICU space. And in terms of ICU space, we used our surgical pods because surgical ICU volume was low. And actually, we transformed one of our holding areas, our cath lab holding area, and eventually our interventional radiology holding area into ICU space. So that was our innovative way to create space. And basically, I will venture to guess that our cath lab holding area, which is now a combined floor status and ICU status unit for our COVID patients. Thomas?
Yeah, so, at each of our 4 hospitals, had to make space where they could for the COVID-19 patients. As everybody knows, getting space inside a hospital is like getting blood from a stone. So really having to work with what we had. So at our larger facilities where there's a lot of tertiary care, there's actually also a lot more geographic space. And so we actually, at Mercy General, for example, I think I even have a picture of this. Is this still in the slide deck? Where we actually took this, yeah, and there it is. So this is what we did on the 2nd floor at Mercy General Hospital. This is the original tower. You can see on the left there's a closed door that you have to go through, and then you get in there, and inside that space is where you can hold a lot of personal protective equipment. And then you can see this is sort of a jerry-rigged negative pressure ward, which looks like a fire marshal nightmare. And I'm actually kind of surprised that it hasn't been cited as a fire code violation. But it did. It just kind of shows you how, we just had to sort of retrofit and just work with the space that we had, because to get all these areas negative pressure was just, it required a lot of retrofitting. Can you go forward one more slide just to and this is what the Mercy Folsom emergency department looks like. Mercy Folsom's in the foothills. And so there's a lot of duct tape there. There's a lot of plastic, a lot of retrofitting. And so that's the way a lot of, for example, on our medical units at Mercy General, we were able to convert a large floor over. I'll talk to this later about just the surge and the waves, but we were anticipating a huge influx of patients, which didn't happen. We converted over one of our surgical units to become a dedicated COVID unit, and that unit actually largely remained closed, or we had no patients in it during the early stages of the pandemic. Moving on to the ICU, again, it was different. For example, a Mercy General, which is a large tertiary referral center, they're able to seal off one of the ICUs in the medical, surgical, neurologic ICU, really close that off. At Folsom, they actually, which has a small 7-bed ICU, they did a remarkable job of just like taping off one half of the ICU, dedicating that to COVID patients. Methodist, which also has a smaller ICU, they actually just individually fit ICU beds so that they were, able to accommodate COVID patients and be negative pressure. So when it comes to transfers, we had an experience with transfers, and Aziz, I know you had quite an experience with transfers. Can you tell us about your transfer experience?
Absolutely. And one thing I would add, that we actually gave up on negative pressure rooms. So we didn't jerry rig anything. Our CDC guidelines changed. So we didn't do anything in that regard. So I thought that was a very interesting compare and contrast to what I'm hearing and what Thomas's group did. And as far as transfers, being a tertiary care center, being in a very competitive market in Chicago, we actually only accepted transfers really from our sister hospitals, community hospitals that are part of our network. Unless a referring center really needed a higher level of care, like CRRT, then we would accept it. If they said, "Hey, we don't know how to prone," then we would say, "Well, there's a New England Journal of Medicine video. I'm sorry, but." And actually, it worked okay. We didn't. I think every medical center in the Chicago area really understood that we just be transferring one COVID to another, one COVID space to another COVID space. And as surge volumes dropped, we realized very quickly that we can't, in the future, use our surgical units. We'll talk about finances a little bit later for COVID again. So, like I said, our holding area is permanently going to be our COVID space. Thomas?
Yeah, well, transfers are really a huge portion of the business at Mercy General because it has a lot of specialty care. The only requirement we made on transfers was that they have a negative COVID before transfer. But despite that, our elective procedures were canceled, as we'll discuss, and the transfer volume just dropped off the shelf, which really left a lot of our very hardworking cardiologists and cardiothoracic surgeons without a lot to do. So for the sake of time, I think I'll move. I think the take-home points are you have to work with the space that you have and innovate as you go along. Aziz?
Yeah, take-home point is be creative in creating a permanent space. COVID is not going away. It's not going to magically disappear. And so we use our pre-op holder as our permanent space. So that's our take-home point there. So
I think
sorry, go ahead, Thomas.
So yeah, so going on to testing, we had a rougher time with testing. I'm really looking forward to hearing you talk about the innovations you did at Loyola. But at the start of the pandemic, Dignity Health in Sacramento was required to send all of the testing to the county, and this led to really slow turnaround times. Initially the testing was real modest. We were able to stay up on it, but it rapidly deteriorated to the point where we were having persons of interest sitting in the hospital for a week waiting for a test result to come back. So even despite the fact that there were commercial tests available in the community, so it was around about April that got relaxed. We were able to use a lot of the commercial tests ourselves. We got the Abbott Now, and we also had our own PCR testing, but that was really not adequate. One of the big things that happened in our community was a biotechnology firm in Folsom called STEM Express converted their testing over. So they actually started doing a lot of PCR testings, and the Abbott Now kind of became our main workhorse, but we were using the PCR. But I know Loyola actually had a very different experiencing with COVID-19 testing. Can you tell us about that, Aziz?
Yeah, so wow, testing I think brings back nightmares for all of us. So like you guys, we outsourced in mid-March. I still remember patient number one. We'll never forget this patient who survived, actually. But yeah, we were sending everything to IDPH. It was a 72-hour at least turnaround, and then we had courier service and all that. And then we quickly developed in-house testing. We had this older machine we were using. We were using the PCR. At that time, we had about an 8-hour turnaround. So we had 2 runs and 8 hours. It was still causing a lot of PUIs. We can talk about PUIs in a bit and how stressful that can be, and taking up room in your COVID unit. But now, actually, we're very happy that we're actually moving to universal testing, which has happened this week. And we actually purchased a very fancy machine, which can give a 2 to 5 hour turnaround with the PCR. It's like an assembly line that continuously churns. So that's very exciting. Now, it'll be interesting to see what universal testing does for all admitted patients. And I'd love to hear at the end what people whether people have had experience with that or not, but in-house testing was a big game changer. The rapid POC, we're probably moving away from, we're having some issues with distributor at the moment. The CEPIAD stat testing, again, very limited. We only had about like 15 to 25 a day to use on the regional level. And that, again, because of in-house 2 to 5 hour turnaround for PCR, we'll use much less stat testing unless there's a super emergent need for a high-risk procedure. And in terms of retesting, so we are not going to retest patients. We're going with the notion that you can't get COVID again, but of course, again, disclaimer that could change. And in terms of COVID recovered, what that means is that we're going 21 days from positive COVID test to say that, okay, we're not going to test you again and you're COVID recovered. That's a little bit more generous than what's out there, but we're using 21 days to be very safe and conservative. And then part of the testing pager, so yes, the hospitalist, which won a lot of hearts and minds from everybody, managed COVID testing approval during this whole time, and it was a painful task, but it was needed to be done to streamline who gets tested, who doesn't. But now, since we're going to universal testing, that's going to go away. So, Thomas, anything else to add?
Yeah, I mean, I really, it's really great that you've gotten the in-house PCR testing. We're still reliant on the Cepheid Express and then also the local STEM Express, which has been doing a lot of the PCRs for us. We're still using a lot of the Abbott now, and which requires a higher viral burden than the PCR to turn positive. So it has false negative rates, but we've actually seen pretty good concordance between the Abbott now and the PCRs.
Yeah, the numbers are out there. We had about a 25% miss rate. So, to your point, the real symptomatic patients will definitely test positive, but the lower symptomatic or asymptomatic patients may miss.
Yeah, we've seen about a 93% concordance rate, so that's been, so we're still using the Abbott a lot, but I'm sure jealous of you in that in-house PCR test that you've got. So, well, I mean, I think that so take-home messages, yeah, if you can get the in-house PCR, that's great. Turnaround is a key, obviously. So for the sake of time, pardon?
I will say that I think universal testing, we will see what happens and what that means to our COVID space. But the last thing we want to do is take our surgical units away because we don't want to do that. So again, no, is not what universal testing means for us. So in terms,
I think that's right on there.
I'm sorry?
No, I agree. Right on there.
Okay. So for care team and rounds, we'll leave virtual rounds for our next slide. But Thomas, tell us about isolating your hospitalists with COVID only and what your experience there has been. Well,
so there are many different levels on which assigning a COVID patient has played out. Looking at the local level in the hospital, pretty much at the start of this, all of our hospitals were sharing the COVID patients evenly amongst the hospitalist individual. And the idea came along that, maybe we should have those patients focused on to one hospitalist, because as we will get to in therapeutics, getting some of these investigational new drugs for these patients was quite laborious, and you really had to figure out how the whole process of getting these therapies, plus the personal protective equipment, the fact that more people are getting exposed. We did pretty much all 4 of our hospitals transitioned over to a dedicated COVID hospitalist. As it stands now, the only hospital that really still has a dedicated COVID doctor is Folsom. I mean, these things are constantly changing, but from an operational standpoint, it seemed to work better to have a hospitalist who is dedicated to the COVID service. The problem is, you can get overloaded with patients. You can get underloaded with patients. You're not generating RVUs. The fluctuations are challenging. This individual stress when you come on service, and that week that you're going to be the COVID doctor and you're going to have to be talking with Mayo Clinic on a regular basis to get, investigational new drugs, pretty stressful. So that's why there's ups and downs. From an operational standpoint, it really worked better for us. But from an individual stress, it became quite burdensome. Now, interestingly, we even tried channeling all of our patients to a dedicated hospital. Mercy San Juan became our go-to hospital for COVID-19 patients when it became apparent that the initial wave of the pandemic in Sacramento was not going to be as overwhelming as we initially predicted. But then it did become overwhelming, and that plan didn't last very long either. So it's really been a constantly moving target in Sacramento. What was your experience, Aziz?
Yeah, so, we, from a regional standpoint, all three hospitals, we were managing COVID patients. As far as our academic base here, we have 4 hospitalist teams. At one time, it was 1 hospitalist team, then 2, then 3, then all 4. Because our peak COVID census was about 125, and our peak, floor census was around 60-ish. So, this was interesting. We, not me, but our hospital medicine chief, dialogued with our specialty patients. Believe it or not, our hepatologists were eager to manage gen med issues, and our cardiology actually took heart failure. It was a pleasant surprise because the hospitals took care of the specialty patients who were COVID positive. And we trained up some of our APPs who were maybe surgical APPs that wanted to work, and they were able to take care of a few patients. Sometimes some primary care doctors came into play. The reason we did all that was to limit each hospitalist team to more than 10 to 12 encounters. These are very, very tough patients to manage, and a lot of it was communication, and especially when a significant portion of our patients were English was not the primary language, and ensuring that our patients are getting the best and offer the best communication. It just takes double the time, which is we have to accommodate. And so what also we did, so then you asked, well, what happened to the rest of the floor, like the non-COVID floor patients? Well, as we all know, heart attacks, heart failure, COPDs were non-existent, but we did have a decent number of, much smaller number of our non-COVID patients. So that's where the resident teams kicked in. They took the primary brunt, so they were maxed out, but we took our OBS unit attending and our co-management attending and changed their roles. We also created an MOD, like an air traffic control, and believe it or not, so the academic hospitalists who are listening to this be like, wow, this actually can happen, where the hospitalist said, no, this patient is going to this service, and there was no questions asked. It was beautiful. I hope that goodwill lasts. And currently we're down to 1 hospitalist COVID team. And it's interesting to Thomas's point that that 1 hospitalist team, if COVID census is low, will first see the non-COVID patients, so not to contaminate, and then go to the COVID unit. So yes, I agree with everything Thomas is saying. Very stressful. I'll talk about interdisciplinary rounds in a bit. But we limited COVID time to like no more than 4 or 5 days. So Thomas,
yeah.
Patient, please, or unless you want to comment on what I just said.
Oh, sure. Yeah. So, so we actually have long had a system of patient assignment inside our office where we've had a non-licensed clerical person that does all of the patient assignments. So doctors don't have to really look at which patient goes where. And so in these clerical non-licensed people, that's all they do is they do patient assignment. So it allowed us to, as this was changing very rapidly, it allowed us to adapt, to change, okay, we're now completely changing how we assign patients. And, these people, that was their job all day long. So that as things were changing, they were allowed to adapt the rules to a rapidly shifting environment. The problem was that these clerical people lived in the office. Our process was a paper-based process. And so the big innovation had to be that we moved our clerical support staff out of the hospital so that they would no longer have any potential for COVID-19 exposures. And it really forced like an innovation that probably was overdue. We needed to switch over from a paper-based process to an electronic-based process. And we're now using Cerner, which is our electronic health record, to really facilitate that. The overnight doctors put their patients in a specific spot. And then in the morning, our clerical support, they send out a secure text message with patient assignments. So that's that it was kind of one of those parts of like how we operated that allowed us to adapt.
Excellent. Yeah, I mean, I don't have much to add there besides our patient placement. They would rely on the MOD or the air traffic control person to help designate service. It's almost like those programs that have the hospital czar. I know some programs have that. Basically, we mimic that for this short amount of time. So moving on to interdisciplinary team rounds. So this is where, now I'm a little biased here because as an ACMO, I took it to myself to oversee the WIN rounds, not as a hospitalist, but as a system or a medical center leader. These interdisciplinary rounds sometimes lasted 90 minutes, 90, with 60 some patients, super complex. And I had an Excel sheet where I looked at number of days of symptoms prior to admission, when are we sending home on oxygen, length of stay in the hospital, and we use home health heavily. We would discharge patients who are symptom onset or dated 3 to 5 days from symptom onset. Now, again, we're discharging into the unknown because we know that patients can get worse on day 7, 9, or 10. And it was a very different thinking, but our hospitals really pulled through. We had very little readmissions, very negligible amount. We discharged patients on oxygen all the time. And I have to brag about this, that our median floor length, let's say if these are patients that actually did not hit the ICU, was 4 when this, I'm gonna bring my DRG clinical documentation thing to the table here, where the DRG 177, which was the majority of patients with COVID infection with respiratory failure and or pneumonia, the GML loss is 5.5 days. So that was, a huge win. And also most importantly, we kept patients safe. And this was, every day we would go back to command center and say, hey, don't worry about opening up a 3rd or 4th unit. We have 15 discharges, 20 discharges. This is where we need interdisciplinary help with. And senior leadership was very aware of all that was happening. Thomas?
Yeah, so what you were able to pull off is very impressive. And I tried to get the utilization data in our facilities. I wasn't able to get that in time for this, but we had, as I think a lot of people have seen, a lot of heterogeneity in our patients, and we had some that stayed a long time. Really kind of one of the big limiting factors was weaning the patients down off of those high flow oxygen before we sent them out. So some people were able to get out fairly rapidly, and those tend to be younger patients. Some of the older, really sick patients took a lot longer, and then they were very, very debilitated when they went out. So
let me be clear. At those patients where we would not discharge on high flow oxygen. And as interestingly though, as this is progressing, we are seeing more complex patients being admitted versus young patients who could go home on day 2 or 3 on oxygen. So it seems as though the acuity definitely got worse as we progressed through this pandemic.
What would you say are the take-home points, Aziz?
Oh yeah, and then as far as students and residents, students were gone.
Sorry.
Residents only manage ICU. and the floor patients were only hospitalists. So that was what we worked out with the residency. Take-home points: be creative in using your hospitalist teams. Use your specialty teams, build those relationships. You'd be surprised, hepatology can manage cellulitis, and the cardiology can actually manage heart failure, and utilize APPs, and leadership in interdisciplinary realms. It doesn't have to be your ACMO or your CMO, and making that leadership visible to the gains that you're making. That's my take-home point.
Sounds good. So
this is you, telehealth.
So, well, I'll keep this fairly brief since we experimented with telehealth for hospitalists at several of our facilities. Long story short, it never really took off. There's really no replacement to getting in there and listening to the patient's heart and lungs. And another thing is that, because we had the negative pressure ventilators in all the rooms, there's a lot of background noise. It's hard to hear the patients. So the place where telehealth really took off for us was more in the outpatient arena. Long before the COVID-19 pandemic, we had a robust telehealth service through medical group, and we're really able to leverage that. So again, I think the take-home points here for us were, it was really hard to make it a reality on the hospitalist side. On the outpatient realm, I think a lot of people saw this, but we were actually able to take it to a new level because we had the infrastructure there long before the COVID-19 pandemic hit.
Yeah, I mean, I think to reiterate Thomas's point, our hospitalists were expected to see patients every day. The consultants used it, but absolutely, this is where telehealth really took off. So, take-home point, Thomas, for telehealth?
Yeah, I think if you can come up with it, great, but it really is something that's been leveraged more in the outpatient realm. So with that, I think we'll go on to discussion of therapeutics and just the logistics of therapeutics.
Yeah, we're not going to go into remdesivir, dexamethasone, hydrochloroquine, azithro, and all the yo-yos that we've been dealing with, reminding ourselves that we stick to science and literature. Remdesivir, at first it was like a clinical trial, but then the New England Journal study came out. So now basically a hospitalist can order remdesivir as long as a patient is hypoxic. That's really the requirement, and the LFTs are okay. You have to obviously go over the consent with the patient. We actually, I mean, as everyone knows, ID services got pummeled during, continue to remain pummeled during COVID. So we're learning, how to manage more ourselves. But when it comes to convalescent plasma and tocilizumab, I'm probably mispronouncing that, we're absolutely making sure that we're calling ID. Now, convalescent plasma, FDA just came up this week with something. But remdesivir, because now that mandates a 5-day stay in the hospital. And what's interesting to see is whether we could have discharged patients sooner if it wasn't for remdesivir. And the jury is out, whether this will increase length of stay or not. Well, I mean, Thomas, I don't know if you have anything else to add there, but we actually don't need any ID. Bottom line is we don't need ID approval or IRB approval for remdesivir usage.
Yeah, it's evolved for us. I mean, and if Aziz, you and your facility have been able to keep down to a length of stay of 4 days, 5 days of remdesivir is gonna add to the length of stay. I actually asked around to see if, because we have used a fair amount of remdesivir, to see if anybody was looking into the possibility of an outpatient infusion of remdesivir, and that hasn't been happening. I know that it's because these were a lot of investigational new drugs, that as we were using them, there was enormous amount of paperwork that had to be done to get that. And that was one of the big stresses of being on the COVID service, was that you had all this extra paperwork just to get the therapeutics going. But at the same time, it's one of those things, like the first time you do a heart failure admission order set, it's really slow. Like, the 100th time you do it, it's a lot faster. So there is an advantage of having the familiarity, knowing how to get the process and getting it done. So, because every time you're reinventing the wheel, really bogs you down.
So of course, Tom, I had to ask a question about length of stay to my ID team. And they looked at me and said, disease is not always about length of stay. I said, of course, but I have to ask. Because it's so new and LFTs and monitoring that we felt it wasn't safe to even put a peripheral in and have them come to the day center and COVID exposures and all that. So the answer was no.
Correct.
Thomas, predicting the waves, why don't you start us off here? This was a tough one.
Yeah, and I think, I'm going to tell you a little bit about the experience in Sacramento, and I think to really outline that, can you just move forward to the graph of the incidence of, so this is what COVID-19 in Sacramento has looked like. So at the very beginning, we had a lot of outside modeling that predicted that our hospitals were going to get overwhelmed, and long story short, that didn't happen. The Governor Gavin Newsom really shut down the state pretty quickly. We didn't see a lot in Sacramento. So you can see that first wave back in March and April. As I mentioned, we set aside entire floors of our biggest hospitals to accommodate COVID-19 patients, and not a single patient ever stayed in those units. So as it was clear that the initial wave was not a problem, things laxed up. Now, going back, the next slide is what it was like in Aziz's neck of the wood. This is what it was like in Cook County. So they had a little bit of up and down, as you can see. Do you have any comments on that, Aziz?
Stay away.
Yeah, so a little bit of up and down, but not the, like, and going to Sacramento County. So we had the right when it was first starting, the little blip, and then things started laxing up. But then it was really around June, July, and then through August that things really kind of blew up in here. I think that was really related to, there's a lot of agricultural land nearby where it was really, a lot of the workers didn't have the opportunity to social distance, and that spilled over to Sacramento. So as I mentioned, we're retrofitting a lot of our hospital units for negative pressure. Aziz?
Yeah, now if I could mention that, though you guys are seeing this big, continuing big spike, if you actually would trend that, it looks like a trend up. But interestingly, June, July, August, our overall in Chicago, our hospitalization rates are low. So definitely it shows you that there's a different demographic that's getting affected in Cook County versus in April. In April, every hospital was going, nuts with COVID census. So very fascinating to see. Numbers are higher than April, but the hospitalization rates are like significantly less, like 120 versus 10. So
that's interesting. Yeah, because the case positivity rate that we saw, really reflected in the hospitalizations, and this, of course, this caused just had huge financial impacts on the hospital. Number one, all of the elective procedures that really are the financial lifeblood for hospitals were canceled. And that's, as much as we are partners with our hospitals, that's where there is, a profit margin for hospitals, those elective procedures. Number two, as I mentioned before, the transfers for higher level of care just bottomed out. We just weren't seeing it. And then, as Dr. Ansari referred to, nobody with heart failure was willing to come to the emergency department anymore. We saw our emergency departments empty. That's changed in the last couple of months, and we're definitely seeing a lot more COVID-19 cases. But the economic impact has really just been devastating. The CARES Act has definitely mitigated it for some of our facilities. Mercy General is hoping to have a positive margin in the third quarter of this year, but it was a perfect storm of three separate forces that just had huge financial impact on the hospital. We'll come back to this a little bit later, but I want to hand it over to Aziz here to chat on this subject.
None of us want to relive that nightmare of April and May. I live in this world of, mid-revenue cycle, and the negative operating margins were a bit atrocious and frightening. We were talking about people's lives, furloughs, layoffs. We can't go back to that. And the financial distress, we're just trying to go back to normal and trying to make up grounds. But it clearly dawned upon me how critical elective procedures and surgeons are to the running of healthcare systems and just everyone's livelihood. And so electives carry a healthcare system. That's a whole different topic for discussion, whether we like it or not. And that's why it's so important that we're this testing, and cohorting patients, and epidemiological issues, and social service issues, and the underrepresented, underserved, who are getting affected more so, and wearing masks, right? We cannot, no one can afford a second hit. That second hit theory, we cannot afford a second hit of being completely shut down again in the fall or winter. I think that's an understatement. Thomas, take home point.
Yeah, so I think the bottom line is good, accurate modeling is critical for planning. We had some modeling that was way off the target, and every model has its assumptions. So, but you got to make commitments to these things, because we didn't want to end up like, with the devastation that Washington and New York had. So, well, I think with that, we can go on to have our palliative care family meeting expert take this next subject and give us some wisdom on what it's like having family meetings and end-of-life discussions in the COVID-19 era. Dr. Ansari.
Yeah, I mean, wow, this is awful. So I was just on service last weekend, and let's just say that communication has diminished, or I think the quality of communication has diminished across the board, whether it's end-of-life issue or not. When families are at the bedside, you make the time, you talk, but and then when nobody's there, and then you're having to call 10 or 12 families. So we are seeing that. We're seeing more dissatisfaction, and I think we have to be proactive as hospitalists and think about how we can do things better. And we're actually come up with a quick 5-day rapid improvement project on improving communication across and all floors, which I'm part of right now. My 5 days are due in a few days to come up with something with my team. But I think visitor restrictions and end-of-life issues are, I just dealt with issue just about 2 hours ago. This is where distrust comes, and I think we have to think, well, can a family member be in the room with gown, glove, and mask? What is the latest evidence in that regard? If a patient has been day 21 plus and trached, and now they're dying, if it's class day 21, can we move them to a non-COVID floor and maybe relax the visitor policies? No patient should die alone, I think, and that's what's really tragic about all of this. I don't have answers, but I'm asking the group here, is myself included, not be dogmatic about these visitor restrictions, keeping everybody's safety in mind, but also keeping in mind the number of symptoms and whether it really is a risk for somebody to be in that room with the patient. Thomas?
Yeah, so when at the beginning of the pandemic, we had a no visitor policy, and I know from my own experience and from talking with my colleagues that we'd have patients that had these severe life-limiting conditions. That's what we do as hospitalists. And I remember talking with a family that was in Vermont. Dad was doing very poorly. I wasn't sure if Dad was going to make it or not. And they said, should we fly out there? I'm like, you can fly out here, but you'll expose yourself to COVID-19 in the airplanes and the airports. When you get here, they won't allow you into the building. So I just had to step up, and all of us just had to step up and really go the extra mile, talk with every next of kin on every patient every day. It just became a mandatory thing that we had to do. There was no longer, well, if I have time, I'll call the family. It was a mandatory. We just had to do it. And it was devastating when I would have patients that, were passing away and the family couldn't be with them. I agree with you, Aziz, that every, being with your family during your final hours is, that's sort of human dignity. And the fact that this took that away from so many patients, we've actually relaxed a lot of our visitation. So we're now allowing, one visitor a day, particularly patients that have dementia, things like that. But we're still struggling, just like you are, Aziz, with what do you do with the COVID positive patient who is dying, and can we bring that family member in there so that they can be with their loved ones during a time when their health is declining, during a time when they may not be with this reality much longer. So
the open is to ask ourselves at our institutions and with our experts is, wait a minute, we're like 28, day 30. Could we think about this differently? So I'll leave it at that with no good answer. So we're on our last topic and we have 10 minutes left. Thomas, why don't you start here about really what it all boils, not it all boils down to, but a key issue of hospitalist and HMG relationships.
Yeah, this was a very big issue. Without getting into a lot of details, I'll just say that relationships in our hospital system and our hospitalist group were strained leading up to the COVID-19 pandemic. I know that was similar in groups around the country. Aziz and I participated in some research on this very topic, but hospitalist groups have become a big line item in hospital budgets, and hospitals have notoriously thin operating margins, and trying to keep the operating margin, in the black is critical to their survival. So this was a crisis, and I hope I say this right. Don't miss the opportunity of a good crisis. When there is a crisis and you're able to rise to the challenge, you have an opportunity to cement relationships. And hospitals need hospitalists, but the reverse is true as well. If you don't have a hospital, you can't be a hospitalist. And so the ability to partner with our hospital system during this crisis when everything was falling apart, to be at the command center, be talking about what are we going to do with personal protective equipment, how are we going to get patients through this process. We started with twice weekly calls, which eventually got into once weekly call. And the fact that we could be there and provide our hospital executives, our hospital system with guidance really allowed them to see that, in a crisis like this, our hospitalist group was going to be there for them. And it's really cemented our relationship. I think, the old saying that, a friend in need is a friend indeed. If you can be that friend to your hospital system, maybe they don't always treat you the way you want to be treated, but you need them, they need you. And if you can be there for them and help them through a critical moment like this, as so many hospitalists have done in so many other situations, you cement that relationship, you create stability in your group. So I guess I've been soapboxing a little bit here, Aziz. So I know that you had a similar experience at Loyola.
Yeah, similar, and granted that, our ACMO and CMO offices, all hospitalists, but really beyond that, we're responsible for the whole medical center, but I would say as far as a division of hospital medicine goes, there was no whining, there was no, they could have whined behind closed doors, but eager to, let's do this, let's take care of this, communication, everybody working together. And remember, you all know that average hospitalist support is a significant amount of our salaries. And the fact that through this crisis, administration saw vividly the value that we're bringing. And also I want to add the humanity of all of this. Thomas and I were talking yesterday. You know, I remember there was that 30-year-old who came back 2 days later in hemorrhagic shock, and the hospitalist who discharged the patient was on the phone. I was in the command center crying, saying, what did I do? Then I started like getting teary-eyed, and I had to walk away, and everybody was like, oh my God, are you okay? And we talked about it. And I think that humanity of such a crisis and between generations, like you're telling a patient who recovered in the floors that, oh, by the way, your mom died while you were intubated in ICU, right? I mean, that is just insane. We were able to bring the humanity of what we're doing to leadership in command center. So it was real. That's my take-home point. Taking the initiative, your hard work will show the results in communication.
That's great. You know, I think we should probably open up for questions given the amount of, that we don't have a lot of time left. Do you want to do that or summarize?
Yeah, let's take questions. Yeah.
Great, and I want to thank you both for taking the time out today to share your experiences with all of us and perspectives. And I know it's been an incredibly challenging past 5 months, and you know, it's always heartening to see how hospitalists are coming together in their own institutions, but then also with us here at SHM to share experiences across the field. So we had a few comments that I'll quickly note and then some questions. And I do want to remind folks, if you do have a question, please type it into the chat box and we'll try to get to as many of them as possible. So some of the comments are around, Thomas, you mentioned that as you keep filling out the forms, you get faster. And that's something I think is something, you know, the grace that we all need to give ourselves in a time like a pandemic. The space to learn how to do things we've never done before and the time it takes to learn how to do them. And also I think the other point made was around seeing systems like FDA approval on some of those forms moving quickly. And so when everyone can orient all the systems to move fast, it's heartening to see. Another comment was around end-of-life care with a provider in our hospitalist in New York in the heart of the pandemic early on, and how their visitation policies have changed and loosened now for end-of-life situations. And one thing that they did use is roving teams with iPads to help facilitate communications between families and patients. So they're using tools that were available at the time. So we do have two questions that are related to staff. The first is on, do you have policies for testing staff? And then the second is, did you have a highly infectious pathogen team that you drew on at your institution? And particularly from bedside RN perspective, how were those providers managed and kind of integrated into the work of the hospital medicine team?
Sorry, can you repeat that the second question, Josh?
Yeah, just around, did either of your hospitals have a highly infectious pathogen team? For example, an Ebola affected patient. And then if you did have that team, how was that, how did that influence the bedside RN perspective? You know, were nurses assigned to the COVID units, drawn from any special pool of staff, or were they, you know, was it sort of the general pool?
Okay, so Thomas, I can briefly start and then you want to add?
Sure.
In terms of employee exposure, we would follow our guidelines from our own ID experts in Trinity Health, and we had low, intermediate, high risk exposure. There was a lot of back and forth, a lot, you know, things kept changing. But if you were exposed and it was not a high risk exposure, you still came to work with, eventually you came to work with temperature checks, masks, to put it short, in a short version answer. The second answer, we did not have that kind of team, very intriguing. And as far as nurses, we took the nurses on that unit and they became the COVID experts. So we did not move nurses around. We just we just trained up. Thomas?
Well, yeah, so we did universal screening every day with symptom screen, temperature screen, which obviously is not, that's not the most sensitive approach, but that way it allowed us to screen essentially everybody that came into the hospital. I don't know, thinking a little, this is my thinking outside the box, but they were checking temperatures on everybody every day. I always thought we should maybe make a pulse ox too, since a lot of times the COVID-19 pulmonary syndrome first manifests in hypoxia, and a lot of people don't even realize that they're so hypoxic. So, but that we never did that. That was just one of my deep thoughts moments there. But so we mainly did a symptom screening process, and if people, like as you experienced, Aziz, if they had a high risk exposure, then there was tracing how risky was it an aerosolized procedure, how high risk was the exposure. Depending upon how high risk, people would be quarantining, and then of course testing and those types of things. But we did have one of our doctors in the early days that was on the COVID-19 service that did end up contracting COVID-19 and got pretty sick, but fortunately survived. And so we seem to, just by using the screening process, using the high risk exposure algorithms, we were able to stay on top of it. And we didn't have the system that was described. It sounds like a very interesting process, having nurses specially trained. We didn't have nurses that were, specially trained for COVID-19. They all have, training on, the different types of aerosolized versus contact restrictions. So we didn't have a special training for them, but we did have specific units where our general nurses were working on COVID-19 patients.
And interestingly, in terms of hospitalists and intensivists, we've had, to the best of my knowledge, and I'm pretty sure of this, no hospitalist or intensivist got COVID. And interestingly, when hospitalists got antibody testing, our in the throes hospitalists who were doing a lot of COVID service, they were really upset that their COVID antibody was negative. So they were like, "Oh, come on. I want to be immunized, herd immunity. What's going on here?" So PPE worked. Yeah, surprising. Not surprising, but interesting. Other questions?
Yeah, PPE works.
Yes, and hopefully the supply can get better. Aziz, you mentioned that, and both of you actually mentioned the profound financial challenges that COVID-19 has presented for hospitals and hospital medicine groups. Can you talk about what measures your hospitals or your groups are doing, putting into place to mitigate the potential second hit? If hopefully it doesn't come, but if it does come, do you have any plans in place to meet that challenge?
Well, yeah. Well, the plans are to keep everything going and not shut down again. And we already have a surge plan, which is use our current space. We have a second holding area space, and we have a third space. And these three spaces we hope, knock on wood, will eliminate the need to close down our mainstay surgical and med-surg floors. And really, it boils down to how people in the Chicago area behave, wearing masks and taking things seriously. School is starting. Hopefully, we'll see what happens there. But that's the best we can do. And just hoping that the numbers stay stable. But that's our backup plan. We have 3 different type of units which can be used without affecting normal business flow. Does that make sense?
Mm-hmm.
Yeah. So, in Sacramento, we've as I think one of the things we realized, I mean, I think most of us probably knew this before, but it became really apparent after we implemented our initial COVID-19 response, was that, you know, elective procedures are really the financial lifeblood of hospitals. As much as we work, you know, nights and weekends to try and make sure we keep our, you know, medical patients, you know, so that we get them cared for so that they, you know, don't go over the geometric mean length of stay. The revenue really comes from the elective procedures, and the fact that our hospitals had to stop doing those elective procedures was just devastating financially. And so, you know, not to mention the fact that there are a lot of people that, you know, where they desperately need that, you know, the total knee. They need that, you know, gallbladder taken out. They need a lot of these. They need it and they deserve it. And so what we can do to keep that going is been really critical. We've actually developed a lot of screening procedures where we're checking the patients for COVID-19, trying to get it with enough lead time so we still get them in for their elective procedures. But, you know, it's not perfect. We had a case where a patient was scheduled for an elective procedure. They were supposed to get their PCR. They came for the surgery. PCR wasn't back. They tried to do a stat PCR, which didn't end up being stat. We got the Abbott Now. Abbott Now came back negative, and so they did the procedure. They're recovering from the procedure, and the PCR comes back positive. So now we're like, wait a minute, the Abbott Now is negative, the PCR is positive. We now have all this staff that's been exposed. What do we do about that? Well, in this particular case, it turns out they ran the PCR again, and the second time the PCR came back negative. But it just, you know, relates a lot of strain that, you know, having an in-house PCR machine like you have at Loyola is like really, I think that's got to become the standard of care. We're still not at that level, and I think being able to get to that level is going to be a game changer.
I agree. One more thing I want to add is, well, thank you. I take no credit for that. But universal testing, I actually will help cohort patients and allow our so we're hoping that that's actually helping our keep our doors open.
I know we're a little bit over time. Are you both okay to stay? There's a few more questions. You both okay to stay on for a few more minutes?
Oh, I have all
sure.
the time.
I got another 25 minutes, or probably have another 20 minutes.
Mm-hmm.
Okay. Are either of your institutions checking antibodies and antibody testing, and how do you handle those patients?
Great question. Thomas, you want me to take that one first?
Sure. Sounds like you've had more experience than we have.
We had an announcement on that today. So actually, we had employee antibody testing, and that's being rolled out in phases by last name. I have to get my antibody test before Friday. For employees only, but interestingly, we just opened it up for patient care, but we are encouraging only using it when you clinically really need it. And an example I can give, because I was on the unit medical directors, was our neurointensivists who have an undifferentiated stroke. Like, why is this young patient having a stroke and they're COVID negative? Well, that would be a case where they would check antibodies. So yes, employees are being tested for antibodies. Yes, patients can be tested for antibodies, but it has to be a really good reason to do it. So we're interested to see what happens with that.
Yeah, I'm not aware of us using the antibody testing at all. And actually, I was thinking about going to donate some blood just so I could see if you know, like you're saying, as you know, if my exposures have resulted in passive immunity. So yeah, we have not used it.
Can either of you talk about any advice around SNF discharge and making that easier for COVID positive patients? I know that's a tall order.
Well, so luckily, and this was awesome, our region, our two community hospitals, they have they have a TCU or say SNF and acute rehab. So one of our community hospitals, we transformed into a COVID SNF, and the other community hospital was COVID free or COVID clear. So when that happened, I mean, that opened up about, I don't remember, like 15 some beds. That was a huge game changer, that within our system, we were able to get a patient to our community hospital and our COVID SNF. We were very lucky, and that really showed our regional system, for those who are in regional systems working together. We got lucky. And I will say that I dealt with my job with a lot of SNFs who were demanding COVID testing, and somebody, so for example, it's all coming back to me. There was a SNF that was said, well, we need 72 hours of no Tylenol, no antipyretics, no fever. And we were like, look, this patient's going to have a fever for a long time. You know, they're COVID positive. We were able to and there was no set rule. That was just a nursing home said that. There was no evidence-based medicine to say that. But because we were part of that region, the hospitalists who were managing COVID were also the same hospitalists who were the rehab doc. And with some conversation with our PM&R docs and the director of care management, who I work with closely, the regional director of care management, we just bypassed that, I think, a silly thing when medically stable and being able to get into a COVID unit. I mean, they have COVID, everybody has COVID. So why do you have to be fever-free for 72 hours? It didn't make any sense. So that was a game changer. Thomas?
Yeah, this has been a real problem for us. And I know I was talking with some of our counterparts in Washington, you know, at the beginning of this, and how devastating this was for them. And I'm sure the same was true in New York. So interestingly, it's an issue. It's a very challenging issue. We have 3 nursing facilities in the area that are willing to take COVID patients. The capacity is nowhere near the demand. But interestingly, what we've seen is that a lot of patients' families don't want their mom and dad going to a skilled nursing facility. You know, because they know that a lot of the big new outbreaks have been in care facilities, to a degree that really hadn't seen prior to this, saying, no, you're sending my mom, no, you're sending my dad to a skilled nursing facility. We're bringing them home and we're going to figure this out. Whereas the parents say, hey, I think would really, benefit from some rehabilitation. They're saying, I'm not, because I think they're time the problem has been vexing. It has also been mitigated by a lot of the fear that these sending patients to skilled nursing facilities. It kind of needs to challenge that way. And it used to be that they had to have COVID tests before they could get out. That has transitioned to this driven calls, as referred to. So yeah, as with everything else, a wild moving target. But it's mitigating factors that reduce or the interest in having family going to their facility.
Okay, and one last question. Obviously, in March, April, May, into June and July, there were a lot, and then probably even today, a lot of supply issues, particularly with PPE. And have your institutions adapted policies and processes that obviously everyone adapted early on, but today, to address potential future shortages or supply chain breakdowns, if they might come up?
Yeah, so we're lucky that we're part of a huge, national Trinity Health organization. So supply chain, a lot of people working hard in the supply chain, ensuring that we have the supplies. At the same time, other areas at Trinity Health would, maybe the supplies would be diverted to them and maybe diverted to us. That was a bone of contention. I think a lot of people were appropriately perturbed when we said, okay, you have this N95 for whole and put it in a brown bag unless it gets soiled. And that was a lot of work and a lot of messaging about appropriately using and safeguarding our use of PPE and being ready and kind of like getting ready for the next wave, so we have enough supplies on hand. And also, like when we didn't have medical students in March and April, and then now they're back and they need to be back. But we try to eliminate duplication and using telehealth to say, consultant X, you don't need to go in the room, don't use a PPE, just use an iPad and call in and talk to your hospitalist or phone the patient. Thomas?
Yeah, I think a lot like most early on, the personal protective equipment was an issue. We're doing pretty well on that now. Every now and then, there's just so much stuff that you need N95, you need shoes and stethoscopes. That we've been facing this recently is just again with the testing. It was inadequate, and at the Abbott now was rolled out. We're able to get good turnarounds, but we've been more on how as opposed to
hey, Thomas, can everyone hear Thomas? Thomas is
up a bit.
Oh, am I breaking up? Let's see. All right. So I'll also the reception. My testing has been challenge for us. We did well for a while, but as I kind of mentioned, we're mainly using the Abbott now. That was our workhorse, and I'm really, Aziz, I'd love to hear about, the PCR testing that you're doing in-house that just is massively turning out the test results, because I'd love to see that in our facilities.
Yeah. So hopefully we answered the question on the PPE. The other thing to add to PPE now is face shields. That just came out from CDC that they're recommending face shields. So pretty soon we're going to be giving a face shield to every provider and highly encouraging use of it, and they can wipe it down between patients or whatever X amount of time. So that's going to be another interesting add to PPE. Even in non-COVID positive patients, they want the use of face shields. It's going to be quite interesting.
Yeah.
Palliative care consult in a face shield.
I know. Well, and then we actually have those negative pressure rooms. When you're in there talking to the patient, you've got your N95 on, you've got your goggles on, you've got the negative pressure ventilator working in there. Like, communication is so difficult in these days, those situations.
And I wonder how other people on the call, like how many people actually gave up on negative pressure rooms. We didn't. It's hard to measure, but we didn't see a spike or quote-unquote hospital-acquired COVID. We don't see it. With our employee infectivity rate is extremely low.
Yeah, well, and that's good to know. I mean, because maybe we should, because it really makes it hard to communicate with patients when you're in those negative pressure rooms and that fan is just blowing, and you're already trying to yell through an N95 mask, and it adds yet another barrier to good, effective patient communication.
Yeah.
Great.
Other questions?
We're actually going to wrap it up. I do want to thank you, and I will pass it back to Luke to close out the webinar.
Thank you, Josh, and we appreciate everyone staying on a little later. Big thank you to Aziz and Thomas for presenting today in our first installment in the Practice Management webinar series. This will be a monthly series, so our next webinar is scheduled for Thursday, September 24th, and will be a panel discussion with 3 healthcare leaders on challenges around staffing during the pandemic. So we hope you can join us for that webinar in September. Well, I hope you enjoyed the presentation. We look forward to seeing you in future webinars in the Practice Management webinar series. Goodbye, everyone.
Thank you so much.
Thank you.